Good afternoon. I am Dr. Aparna Simha. I'm a pediatrician, consultant at the ORDI. ORDI is Organization for Rare Diseases India. It's an umbrella organization which caters to the needs of all the patients, all the rare, all the patients suffering from rare diseases in India. I welcome you all to this Rare Info Series conducted by the Organization of Rare Diseases India. And today's topic is home mechanical ventilation basics. Home mechanical ventilation provides respiratory support outside of a hospital setting, enabling patients to manage chronic respiratory failure at home. It's a key treatment option for individuals with conditions like neuromuscular diseases, thoracic deformities, and obesity-related hypoventilation. Home mechanical ventilation can improve the quality of life, prolong survival, and reduce the need for hospitalization, and thereby it cuts down the cost of management of these patients. It has to be done under the guidance of a healthcare professional. Patients and their caregivers require proper training on the operation and maintenance of the ventilator. The treatment plan should be tailored to the specific needs of each patient. In essence, home mechanical ventilation is a valuable treatment option that allows individuals with chronic respiratory conditions to manage their health effectively and live more independently in their own homes. To throw light on this very important topic, today we have Dr. Neha Mohan Rao. Welcome you, ma'am. Thank you for agreeing to talk to us about this. Dr. Neha Mohan Rao is a pediatric pulmonologist at Manipal Hospitals, Bangalore and Bangalore Baptist Hospital. She completed her pediatrics post-graduation from St. John's Medical College and Hospital and Bangalore Baptist Hospital. She did her fellowship from Birmingham Children's Hospital, UK. She has been awarded the European Diplomate in Pediatric Respiratory Medicine in 2022. Her areas of interest are pediatric allergy, pediatric sleep, long-term ventilation, and pediatric bioethics. In her free time, Madam enjoys traveling with her family and hiking up the mountains. Welcome you, ma'am. Thank you.
Thank you so much.
Ma'am, over to you.
Thank you, Dr. Aparna. Good afternoon, everybody. Thank you for the opportunity for speaking here today. Thank you to the ORDI and Dr. Aparna for such a wonderful introduction. If I may please now share my slides, if that's okay.
Sure.
Could you confirm to me that you're able to see my slides, please?
Yeah, we can.
Yeah, it's okay. Great. Yeah. Okay, thank you. So my name is Neha and I work at Manipal Hospitals, Bangalore. I also visit Bangalore Baptist Hospital to help children with respiratory problems. So basically today I would like to speak about home mechanical ventilation, and this topic is close to my heart, but also very, very important for us, especially when we want to manage children with chronic respiratory conditions at home. For today's talk, I'd like to begin with a slight introduction as to what is home mechanical ventilation. I would then go on to discuss when we start home mechanical ventilation, what are the underlying conditions, what clinical symptoms do we look for, and what is the importance of doing a sleep study or a polysomnography. I'll then touch upon how home mechanical ventilation helps children and different terminologies that we use in home mechanical ventilation, in very basic terms, CPAP and BiPAP. And then look at some practical aspects of, what do we need in terms of equipment when we speak about home mechanical ventilation, what are the costs involved, what kind of comorbidities do these children usually have, and what could be potential complications. In addition to this, just a little bit about troubleshooting for parents of children who are on home mechanical ventilation, what they must do when their child is unwell, and we will conclude with a quick summary. So to sort of begin, I think Dr. Aparna has given me a nice foundation. We use the terms home mechanical ventilation long-term ventilation and non-invasive ventilation quite synonymously. Home mechanical ventilation and long-term ventilation essentially mean the same thing. That is, you're using a ventilator device or a device that is used for respiratory support at home, that is outside of the hospital setting, and usually long-term. Now, when we say long-term, different organizations from Europe, different organizations from America use different definitions, but I would like to say about 6 hours per day for a period of longer than 3 weeks. Now, this kind of home mechanical ventilation support could be 24/7 support for some children who require it, but it could be just support during sleep for some children, or it could be just nighttime support as well. It would depend on the underlying condition. We use portable ventilator devices with pediatric specific settings. I'm a pediatric pulmonologist, so most of this talk is relevant to children. And we can deliver the ventilation either through a mask, as you can see in the small picture here, there's a mask on the nose, or some of our children require a procedure called tracheostomy, where they have a small hole in the front of their trachea, and we connect the ventilator to that. Now, we use it in several settings. We use it for children with airway problems, which means if they have any kind of obstruction or weakness of the breathing pipe, that is the pipe that's right from the nose or the mouth all the way down until their trachea and their lungs. We use it for some children who have lung parenchymal problems, especially those that, stay for a long time in the NICU, have chronic lung disease of prematurity, or any other kind of chronic lung disease. We use it commonly for those with muscle problems or chest wall problems. So we have children with neuromuscular disease, which is a big cohort of children who require this kind of support at home, but also children with scoliosis, for example, who would require support with a ventilator machine. And we also use it for some children who have CNS problems or central nervous system problems, which means that there is a problem with the respiratory center in the brain, or they have other conditions of the brain like a tumor or trauma, and they need help breathing at home. So while home mechanical ventilation is a very broad term, in this talk, I'm going to refer to home mechanical ventilation as a long-term ventilation setting or in the home setting and not in the acute setting when the child is in the ICU. So when I say home mechanical ventilation, basically a home mechanical ventilator is a device that produces air with a very high flow. How does it do this? It does this because it has a turbine, which is basically connected to a power source, and it generates airflow. That airflow is delivered to the airway. And when you can look at this picture on the right side, you can see that there's a machine, and the machine delivers via a pipe and a mask air into the air pipes, and it sort of delivers that air with pressure into the airway and the lungs. So it does many things, and to keep it as simple as possible, if the mask is fitted tightly on the face, because you're delivering air with quite a bit of pressure, if the air pipe below it is narrow or weak, it sort of stents it or keeps it open. For example, if you have a straw that is sort of collapsed and you breathe air into it or you blow into it with force, it's going to stent it, right? It's a similar sort of function that the home mechanical ventilator does. But it also helps sometimes deliver oxygen to the lungs and helps with ventilation or removal of carbon dioxide and to ensure that ventilation in the lung remains normal. For those who have muscle problems, neuromuscular children, it helps augment muscle function. It helps them breathe in and breathe out, allowing the chest to expand. And if for any child who has a problem with the brain or the central neurological drive for breathing, suppose the child forgets to breathe for whatever reason, then the machine is capable of triggering a breath and helps the child then take in a breath and sustain ventilation. So what are the advantages of using a home mechanical ventilator? I think the biggest thing is that, of course, you can use the machine outside of the hospital setting, so you can use it at home. It is portable. It is very convenient and easy to use. Most machines come with humidifiers, and we suggest that you use it with humidification because humidified air is easier to breathe. It's not cold and dry and irritating, especially for the upper airway. There are several pediatric and adult masks available now, so delivering this is quite easy. And as I mentioned earlier, it can be set up at home and doesn't require hospitalization. It's very, very useful. Not only is it useful to keep you healthy, especially if you have an underlying condition, but it helps prevent illness. It helps reduce frequency and duration of hospital admissions, especially chest related, and overall it leads to a significant improvement in quality of life. But all of these advantages that I've spoken about are only applicable if the machine is used consistently. And that's one of the most important take home messages of today, that if we decide to commit on this journey of home mechanical ventilation, we should be committed to it and use it on a daily basis. Only then are we going to be able to see long term effects of home mechanical ventilation. So, coming to the next section of when do we start home mechanical ventilation? Now, if you look at this picture, this is the normal physiological balance. So, what you can see right at the bottom is a sort of a balance that's on the right side of the screen. You can see the brain that is giving out the drive for the muscles to breathe, which means it's sending neurological signals. The respiratory center in the brain is in the brain stem, and the brain stem sort of instructs the muscles to allow the chest to expand. And every time you have the chest expanding, because there's a change in the pressure, there's air that goes into the lungs, and then you breathe it out passively. Now, this is on the right side of this little balancing scale. And on the left side, you can see that there is respiratory load, which means anytime that you have either an obstruction to the airway, or you have a problem with the lung and the lung is diseased, or your chest wall or muscles are not functioning properly, there's an increase in the respiratory load. And the job of the human body is to always maintain this balance to ensure that we are able to breathe in well, in and out well at all points in time. So if you have an abnormality anywhere, let me first take an example of an abnormality in the CNS or a condition where you don't have the drive to breathe at all. For example, a very rare condition called congenital central hyperventilation syndrome, where there is a genetic mutation because of which children or newborn babies may have apneas, which means they forget to breathe for certain periods of time. Or you could have other conditions such as a brain tumor, trauma to the brain, encephalitis, degenerative diseases of the brain, or any other conditions related to the spinal cord. At that point, when you don't have the central drive to breathe, that can cause a problem. And these are all candidates for home mechanical ventilation. On the other hand, if you have a problem with the pump or the muscles, for example, all of your muscular dystrophies, also, for example, SMA, DMD, other congenital muscular dystrophies, or other conditions of the muscles where the diaphragm is not working, or the intercostals or other muscles of respiration don't work very well, even then you can have a problem. And even then, the balance is sort of tipped, the load exceeds the amount that the body can handle, and you need NIV in these sort of patients to restore the balance. Or when you have an increased respiratory load, for instance, you have a child who has a lot of resistance to breathing because the air pipe is blocked because of obstructive sleep apnea. That could be because of adenotonsillar hypertrophy, for example. Or you have a child with a weak airway, like a laryngomalacia or a tracheomalacia. Or you have children with other kind of lung conditions, for example, bronchiectasis or bronchiolitis obliterans, or chest wall deformities. In all of these conditions, the load on the lungs and the airways is too much, and therefore the balance is again tipped. So, what does a home mechanical ventilation or NIV, which is non invasive ventilation, essentially do? It helps support the breathing and sort of tries to maintain the balance at all points in time. I'm going to come to the physiology of this a little bit later on, but basically, we need to understand that whenever we have a condition where there is an abnormal central drive, or we have a problem where our muscles or our respiratory pump is not working, or we have an excessive load on the lungs or the air pipes and it's not functioning properly, NIV plays an important role. And in all of these conditions, it is very, very important that we use it long term. So, what does it essentially do? It helps unload the muscles. It relieves the airway obstruction, because if the obstruction is causing narrowing of the airway, by pushing in air with pressure, you're helping keeping the airway open. If the lungs are not recruited very well, which means all the air bags in the lungs, which are the alveoli in the lungs, are sort of closed, it helps lung recruitment. If your muscles are weak, it takes over the job of the muscles, and therefore your muscles are able to rest or cope. And it also provides a backup rate. In case your brain is not giving signals for the body to breathe, the machine is able to detect that you're not breathing for a few seconds, and it triggers off a breath and therefore sort of sets back the balance. So, what are our clinical indications? So, when do we look at starting home mechanical ventilation? Now, the most important thing to remember is that hypoventilation or having shallow breathing usually begins at night. And a lot of our children who have underlying conditions that I've mentioned before can sometimes be completely asymptomatic. Even if they are asymptomatic, there are a few clinical pointers that tell us in examination or in their general, mobility status or scoliosis that tells us that, this is a child who's going to deteriorate in terms of their lung function over the next few years, and we've got to start them on home mechanical ventilation. So what kind of symptoms do we look for? We ask for snoring, we ask for mouth breathing, we ask for a lot of nocturnal arousals, if the child is having very restless sleep, if they have awkward sleeping positions, if they tend to sleep with their necks extended. We ask if they have a lot of respiratory effort during sleep or if the family has noticed any pauses in breathing at night. Some of our families are able to tell us that my child gasps at night as well. And we also ask for symptoms such as a secondary nocturnal enuresis, which may be a reason, the reason that the child is waking up may be causing the child to go to the bathroom again and again. So, we ask for indirect symptoms as well. We ask for some symptoms of morning headaches and irritability, indicating that the child has had a poor quality of sleep. We look for changes in behavior, in learning. We ask if the child is falling asleep in school, if the child is excessively moody, aggressive, or angry. We also ask for a lot of daytime drowsiness, if there are cognitive problems that the school has noticed. And of course, we look at children who have recurrent respiratory infections and are not gaining weight. So, all of these things sort of give us clues that these children may benefit from long term ventilation or home mechanical ventilation. But as I mentioned earlier, some of these children can remain completely asymptomatic. And the moment that they have a change in their mobility status, for instance, a child with neuromuscular disease with Duchenne muscular dystrophy is not walking anymore and is wheelchair bound, or develops severe scoliosis, or has recurrent infections. These are the kind of patients that we sort of think of home mechanical ventilation for. So there are a few indirect ways to sort of assess lung function, especially in neuromuscular disease. We can do a PFT, but not all children with neuromuscular disease are able to do PFTs. And therefore, we must remember that doing repeated PFTs again and again may not be the best way to assess these children. Doing a clinical history and examination may be more useful. And if at all we have the facility of doing polysomnographies or sleep studies, that is the best way to decide whether these children require um, home mechanical ventilation or not. When we do a PFT, we do look at something called a forced vital capacity, and that sort of tells us when to start NIV. Of course, the other way to sort of assess whether children with neuromuscular disease have strong muscles or not is to get them to cough into a device called a peak cough flow meter. And we have certain values which again tell us that this child may have respiratory insufficiency and may not be able to breathe and clear airway secretions and will improve with NIV. So I've mentioned about clinical pictures. I've mentioned about PFTs that we can do. I'm coming to polysomnography, but there are some conditions, neuromuscular and non-neuromuscular conditions, which have very specific indications for starting NIV. I haven't covered that in this presentation because I think it's beyond the scope of today's talk. But for instance, if you have SMA1 or if you have DMD, we have international guidelines as to when we must start NIV. And for non-neuromuscular conditions such as obstructive sleep apnea as well, we have guidelines that tell us when to intervene and when to start NIV. But I haven't covered that in today's presentation. A word about sleep studies or polysomnographies before I go into the crux of home mechanical ventilation. Usually, we look at clinical signs or symptoms, but when possible, we like to do a polysomnography. It is very useful because in children who are asymptomatic, it will tell us objectively how many problems are there during sleep. It has to be done ideally in a dedicated sleep lab. This is what a PSG looks like. Now, I know the picture may be a little bit overwhelming, but it's not too bad. You have a couple of EEG leads or electrodes placed on the brain. Sometimes we have a few things placed near the nose. This child, of course, young adult, of course, has a BiPAP mask attached to him. We have a few electrodes placed on the chin. We have some bands across the chest and the abdomen. We have a body position sensor. We have some things connected to the leg, and all of this is hooked up to a computer. And we have a respiratory technician or a sleep study specialist who looks at data all night to be able to assess and tell us what kind of events are happening at night, or to be able to quantify and tell us whether there is hypoventilation or not. And based on that, we decide that the child needs home mechanical ventilation. We can also do something called a titration sleep study. So once we begin doing home mechanical ventilation for a certain child and we start with what we're giving the child is adequate or inadequate, we can do something called a titration study where we bring them into the lab and we sort of see what kind of settings they need in order to eliminate all respiratory events and give them a good quality sleep at night. So when we look at sleep studies, we basically look at how many apneas and hypopneas children have. When we say apneas, we basically mean they are pauses in breathing. And when we say hypopneas, we mean episodes of shallow breathing. You can look at the picture on the right. So on the top is normal breathing, which is breathe in and breathe out. When you have shallow breathing, you don't have very good sustained breathing in and breathing out efforts. And when you have, and these shallow breaths are what are called hypopneas. But when you have apneas, you can have a complete cessation in breathing, and this happens quite often in children. You can also see through the night what kind of oxygen levels are, how the oxygen levels are holding up. Is there any carbon dioxide building up? Carbon dioxide levels increasing are telling us that this child is hypoventilating or having shallow breaths at night. We also look at how many arousals there are, because every time that you have an oxygen sort of dipping, let's say, or something that's disturbing the sleep of the child, the brain can wake up, and this may not necessarily lead to an awakening, which means the child may not necessarily open his eyes and sit up or be awake. But just the fact that child's brain is waking up really often tells us that the quality of sleep is not good, and therefore looking at arousal sort of helps us as well. And therefore, based on a sleep study report, even if the child has no symptoms at all, doctors can sometimes recommend starting home mechanical ventilation, and that's perfectly all right. So, to come to a little bit of how home mechanical ventilation actually helps. So, it helps keeping the airway open. Now, let's say we have a child with an airway problem, and let's assume the problem is a weakness in the muscles of the breathing pipe. So, tracheomalacia, for example. When you give home mechanical ventilation, non-invasive ventilation from outside and deliver air with the pressure, it keeps the airway centered. And at night, when the child sleeps, the amount of energy the child is using in order to keep that airway open during sleep reduces. So, whatever calories the child is consuming is not taken up by just the work of breathing, and the child's weight gain slowly starts improving. Similar to this, the neuromuscular disease, when you have a child with a muscle weakness and you use an NIV machine or a home mechanical ventilator at night when the child sleeps, the home mechanical ventilator delivers breaths with a pressure into the chest, allowing the chest to expand during inspiration and deflate or contract during expiration. It helps unload the respiratory muscles, which means it does the job of the muscles at night. The muscles get rest at night, therefore, your daytime functionality is a lot better, but also the amount of calories that the child consumes in just breathing sort of reduces. Therefore, again, the child ends up gaining weight because at night, the breathing is taken over by the machine, the muscles can rest, all of the calories consumed are not just going wasted in breathing, and therefore, the child starts gaining weight. Similarly, in a lung disease, if you have a lung parenchyma disease, for instance, you have a newborn who's come out of the ICU with chronic lung disease or prematurity, in order to maintain good oxygen and carbon dioxide levels and make sure the child has no symptoms, we use non-invasive ventilation. This also helps with quality of sleep. The brain is not waking up again and again. The number of arousals reduce. And the moment you have better sleep quality, you have better daytime functionality. Your mood is better during the day. Behavior is better. Learning is better. There is no pulmonary hypertension, or the amount of pressure that is put on the heart because of lung disease sort of reduces. And overall, better sleep leads to better growth, better immunity, and so lesser chances of respiratory infections. So, home mechanical ventilation is really useful because it has many advantages, especially in children who have chronic diseases of any sort. Just to brief upon what CPAP is and BiPAP is, we use the term CPAP, and CPAP means continuous positive airway pressure. BiPAP or BPAP is another word where we have bi-level positive airway pressure. Now, positive airway pressure is quite self-explanatory. It basically means you're giving pressure to the airways externally. And then when you look at CPAP, the amount of pressure that is delivered during inspiration or inhalation and expiration or exhalation is the same. Whereas in bi-level or BiPAP, the amount of pressure you deliver during inspiration is higher and the amount during expiration is lower. Now, to keep it simple, in CPAP, you're breathing out against the same pressures as you breathed in, whereas in BiPAP, the pressure is lower when you're breathing out. So it's a little bit easier to use. It's more physiological because when you're breathing out, it's easier on the body. And so we tend to use more BiPAP than we use CPAP, but of course, we use both given depending on the underlying circumstance. So if I have to go about talk about the types of home ventilation, depending on how it is delivered, we can classify it into non-invasive ventilation where we use masks either on the nose or the mouth and the nose. And we have invasive ventilation where we deliver via a tracheostomy tube, which means there's a small hole in the trachea or the breathing pipe and a ventilator is connected to that. Now, a few practical, aspects about using a non-invasive ventilator at home. So this is what a non-invasive ventilation machine looks like. It's quite small and compact. In the first image on the left side, the one on top, you can also see that there are two boxes. The second one is a humidifier. All non-invasive machines usually come with a humidifier attached. There are a few other things. For example, the tubing that is there, you can see here we have a single tubing, whereas this ventilator is connected to a dual limb or a double limb circuit. For children who have tracheostomies, we of course have another humidifier or an HME filter, and we have another connector that sort of connects into the breathing pipe here on the anterior part of the neck. We have different kinds of masks that we use, which I will speak about. We need a power source, so we need some electricity along with a UPS or a battery backup because these machines are electricity dependent. Of course, all machines come with some battery backup, which may be 4 hours, 8 hours, depending on the machine that you pick up. But having an alternate power source is important. And if you look at masks, this is an image of some of our children. On the left part of the screen, you will see simple nasal masks like nasal pillows. You can see all of these children that are using them. They are easy to use. They're quite friendly because it allows children to eat, talk, drink while they're, having the NIV machine on. So it's less claustrophobic as well. In the middle, what you see are a different type of nasal mask that we use, which sort of sits on the bridge of the nose. And you can see many of our children are quite comfortable with it. Again, advantages are quite similar to the nasal pillow. But on the right side of the screen, you can see the oronasal masks, which are slightly larger masks, which cover the nose and the mouth. These are very useful for children who keep their mouth open while breathing at night and have difficulty keeping their mouths closed. Using a nasal mask in those kind of children may not be very effective. So we use these oronasal masks. The only disadvantage of that is it's a little big and a little claustrophobic to use. But in terms of getting used to it, children do very, very well. All of the masks have headgear, which are these straps that we attach to the back of the head. And these are how they sort of use these machines at home. There are a few adjuncts as well. So for a child with a tracheostomy, we sort of use this small connector to connect the ventilator or other devices to the tracheostomy. This is a small handheld suction device that most of our parents use. These are small connectors that we use to connect oxygen onto BiPAP machines, especially when children are unwell. And the last one is a connector where we sort of use, sometimes some of our children don't tolerate any of these masks, and we use the regular HFNC prongs. In the ICU, we use high flow nasal cannula oxygen. So we use those prongs connected to a BiPAP machine, and we use specific connectors for those. In addition to this, oxygen concentrators at home are also important. In terms of costs, we have a whole range of ventilators, right from the most basic one, which I think you can get for about 40 to 45,000, all the way up to 6 lakhs, maybe even higher than that. And each of these machines offer different features and quite sophisticated. The masks typically cost anywhere between 4,000 and 6,000 rupees, depending on the make of the mask. And the tubing is a one-time purchase, about 1,200 to 1,800 rupees, again, depending on what you're buying. There are some things that need maintenance. For example, we need to keep the mask clean. We need to change the filters in the NIV machine as per the manufacturer's recommendations. That's usually once a month. We have to keep the water in the humidifier clean. We usually either use distilled water or boil and cool water, but there are specific instructions from manufacturers, and we have to keep the water in the chamber clean. We also need to have UPS or battery backup in case of power failures because these are machines at the end of the day, and if they give up on us at night, then it's quite difficult to manage. So a few pictures of some ventilators, of course, the ones that are on the leftmost of the screen, the BMC and the Oxynova are uh, more basic machines, but they do the job. And then you can see that there are some ResMed machines, some Philips machines, a whole Brias Vivo range of machines, and a Lowenstein Prisma machine. All of these are in increasing order of their cost, but come with very, very specific pediatric friendly features and therefore are quite comfortable to use for children. Coming towards the last bit, so a lot of our children can have swallow dysfunction, and we may many times say that your child has a swallowing problem. You need to sort out the feeding with either a tube feeding or a gastrostomy or a peg feeding, because these children may, when we put masks like BiPAP masks on their face with a lot of pressure, it can sort of lead to a little bit of aspiration, or the saliva and oral food can go and get stuck in the throat. So we just need to make sure that children have safe swallows before we sort of start BiPAP. We also need to assess their cough strength, and some of them require additional devices, like these devices that you can see on the right. They're called cough assist devices, especially children with neuromuscular disease, which we use intermittently along with BiPAP machines. Some of our machines, NIV machines, come with inbuilt cough assist features as well. And other things like whether or not the child requires tracheostomy, what kind of support they need for their spine, what kind of support they need for ambulation, all of these play an important role in keeping respiratory health and therefore are indirectly related to home mechanical ventilation. Most of our children also require physiotherapy on a routine basis. What are the complications of using a non-invasive ventilation? Most commonly, we see skin irritation, dry eyes, and some pressure ulcers, especially over the nasal bridge. But very rarely we see things like the stomach becoming really distended, child having a little bit of nausea and reflux. We can also see that if used over a long period of time, some of their facial features tend to change because there's pressure on the nose and the mouth from the mask. Rarely we see things like aspiration or pneumothorax, but I wouldn't be too worried. It's generally quite a safe method of delivering respiratory support at home. And as long as we're taking care of basic precautions, we don't see too many complications. Troubleshooting for parents, even when the child is sick, please use your NIV machine. This is something we tell all of our parents. They need to be using the machine when the child is well, but they need to be using it even more when the child is sick. And when the machine doesn't work, we have a small little checklist. We ask patients to check the power source, make sure the mask is fitted really well, check the ventilator screen and send us screenshots of what's going on that machine, observe the child's breathing, and if they're unsure, we always provide them with a contact number that they can reach out to. So basically, we need to ensure the child is stable, both in terms of how comfortable they are on the machine and in terms of their feeding. We need to make sure the parents and the families are trained with not only using the machine, but everything else that comes along with it, suctioning, ensuring the child is using the machine well. If there's a tracheostomy, taking care of the tracheostomy. The home should be suitable as well. So they must have the ventilator in their house, but they must also have a clean house with power supply and an oxygen cylinder if required, or an oxygen concentrator. And they must have a doctor, a pediatrician nearby who is available for any small troubleshooting. Of course, we as a care team provide some contact numbers as well so that we're able to reach out and help families when they need help. In order to summarize, basically, I'd like to say that home mechanical ventilation is not easy, it's quite complex, but it definitely improves sleep quality, life expectancy, and prolongs survival in children with chronic respiratory diseases. Parents and caregivers are key partners for success, so we must always listen to what families are telling us, and this is a shared decision making process. It's a commitment from the families and from patients, but it's definitely worth it. Um, These are how most of our children are on wheelchairs and they're on a home ventilator. But of course, parents are quite burdened because they have so many other machines that they need to take care of. But having a good medical team sort of helps ease the burden on families. I'd like to conclude with our experience, and these are just patients that are on routine follow up with us. I think if we include those who don't come back to us regularly, our numbers may be twice this. But we have about 500 odd children who are on home mechanical ventilation. These are children with neuromuscular and non-neuromuscular disease, of which a very small proportion of children have required ventilation via tracheostomy. Most of them do well with just masks. And amongst the neuromuscular children, the ones with DMD and SMA type 2 are probably the most common diseases that we deal with. the ones who are non-neuromuscular, I think the biggest cohort is those with obstructive sleep apnea because of adenotonsillar hypertrophy, and those with different kinds of syndromes because those kind of children have multiple issues that lead to respiratory problems, and non-invasive ventilation really helps them. Thank you for giving me this opportunity. I'm happy to take questions, and sincere thanks to my teams both at Manipal Hospitals and Bangalore Baptist Hospital. Thank you.
Thank you so much. Thank you, Dr. Neha. That was a exhaustive and very beautiful lecture on home mechanical ventilation. I'm sure everybody has benefited from this. Thank you so much.
And ma'am, we have
Yeah,
few questions from attendees.
yeah, I'm checking that.
Yeah.
Dr. Neha, we have a couple of questions. One, Dr. Anshu Mishra wants to know if we need to replace the masks as well periodically.
So ideally, yes, we need to replace them because they get dirty and damaged over a period of time. The additional factor is children keep growing and their facial anatomy keeps changing. So what is fitting them when they're younger may not fit them when they're older. But I think this is a problem that the pediatric population has. In adults, we usually suggest at least an annual replacement of the mask because it tends to get worn out, if especially if you're using it every day, but sooner if the mask is damaged.
One more question. What should be the range of VT on a trilogy B for young DMD adult with OSA? What happens if it is zero? The second one is the alarm indicates minute volume low on Lowenstein primer. Keeps happening constantly. What does it indicate?
Okay.
This
So
is
I'll take the
from a patient.
first part of the question first. The first part of the question is what should be the range of tidal volumes? Now, for pediatrics, at least we usually aim for 6 to 8 ml per kg. So depending on the weight of the patient, we usually aim for anywhere between 6 to 10, all the way up to 10 ml per kg. That should be the range that you're looking at, even for a young adult with DMD with OSA. What happens if it is zero? There's something definitely wrong. Most likely you have a leak in the circuit. So either the mask is not tight enough and therefore you're not delivering any ventilation at all, or there is a leak somewhere else in the circuit and the ventilation is not getting delivered. If your if the tidal volume is showing zero, you are not giving adequate ventilation and you need to relook at what is happening. The second part of the question is the alarm indicates minute volume low and it keeps happening constantly. What does it indicate? Now, minute volume is basically tidal volume into respiratory rate, right? So you have to look at two things. First, the most important thing that's affecting the minute volume is likely your tidal volume and or your VT. So you need to make sure that you're giving enough pressures so that you're giving that same range of 6 to 8 or 6 to 10 ml per kg tidal volume. The moment you deliver tidal volume and the child is breathing with his own respiratory rate or you've given a backup respiratory rate, your minute volume should automatically get corrected. Minute volume low is telling you either the tidal volume is low or the respiratory rate is low, and you need to adjust one of them to make the minute volume normal. The other thing that you can look at, if you think everything is fine, your tidal volume is fine, your respiratory rate is also fine, is to check your alarm settings, of course. If your alarm settings are not set properly for the age and weight of the child, then you can have alarms that will beep off that don't make sense. So, I mean, I hope that helped. But if anything further, then please feel free to reach out to me on my email address and I will be able to help you with more specifics. I can put my email address in the chat box.
How to deal with air leaks, especially in pediatric age group one? Air leaks.
So the beauty of an NIV machine is it compensates for a lot of leaks because it gives air with a lot of flow. It's not like an ICU ventilator. You know, an ICU ventilator doesn't like leaks, but in NIV we tolerate 20 to 30% leaks. So usually we don't have problems as long as the mask is fitted reasonably tightly. That also we say just keep 2-finger gap between the straps, you know, below the straps, so that it's not too tight, but it's tight enough to deliver it without a significant leak. You should be okay. Leaks usually don't tend to be a problem for pediatrics because the machine is so well equipped and gives air with such a high flow rate that it compensates for all the leaks. And we accept 20 to 30% leaks, so it should not be an issue.
Then it will not affect the precise FiO2, is it?
So that's the other
The
thing about
oxygen.
non-invasive ventilation. If you have, yes, if you need to give lower FiO2s, let's say between the range of 40-50%, you can manage it because it has to go through that circuit. It's not ideal for any child who requires high FiO2s. So if you're requiring very high FiO2s or very bad lungs requiring high pressures and more uh, targeted sort of ventilation, you need to swap to an ICU ventilator because that will be able to deliver it better. So that's for a sick child, you may not be able to deliver very high FiO2s with a non-invasive ventilator.
And we cannot.
Aparna ma'am, I think we have a few more questions
Yeah.
from attendees.
Shall I read them out, ma'am? So I can
Yeah,
see
yeah,
them.
yeah, yeah.
So I think they said, ma'am, is there any pulmonary guidelines documents which a parent can show to doctors if the DMD child is admitted due to pulmonary crisis? So that's a very good thought. International guidelines for muscular dystrophy do exist, but when you have a pulmonary crisis, uh, it sort of tells you to escalate care, and there is no specific guideline as to how you should manage it. My suggestion to you would be that most of our children, we give out our numbers as pediatric pulmonologists and say that anytime you're sick, just get your local doctor to talk to us because we will be able to help fine tune smaller things. For instance, we tell them don't take, if most of our DMD children use BiPAP just at night, right? So we tell them to use it both during the day and at night. So increase the number of hours of usage to prevent an intubation or prevent any invasive ventilation. The second thing we tell, sometimes we increase the amount of pressures that we're giving because when you're sick, you generally tend to have a higher requirement. The third thing that we commonly have problems with is connecting oxygen into the BiPAP machine because every machine is different and most centers we don't know where to connect the oxygen. Should we connect it to the mask? Should we connect it to the machine? So that also we can help you with via a simple video consult. And the fourth thing that we usually have problems with is a lot of our patients tell us the O2 is high, CO2 is not okay. And so we can adjust settings, including things like smaller things like eye times, respiratory rates, if we know the clinical context. So we can also source to you cough assist devices and other devices that will help these children when they're very, very sick. So my suggestion to you is please reach out to the primary pulmonologist who has started the non-invasive ventilation. But in the meantime, I take your suggestion very seriously. And I think it's a good idea for us to give them all a plan of escalation to sort of carry along with them so that if they reach a hospital, at least the hospital knows what to do while they're getting in touch with us. So that's a good suggestion. We will think of that. Thank you.
Somebody else wants to know when a child refuses to put the mask as he feels he does not get proper sleep with mask, what should a parent do?
Yeah, so this is a standard problem for us because it's really not easy to put that mask on a child's nose or nose and mouth, especially because it also comes with a machine that gives a lot of air, with a lot of pressure. And no, nobody likes it. If you put it on an adult also, no one's going to be happy. So we have standard ways in which we speak to parents. We tell them that first put on the mask alone without the machine in the daytime when the child is happy and active. Keep it on for 10 to 15 minutes, let the child play. Then bring the machine with the airflow close to it and just, hover around so the child gets used to that sound and that air pressure. But even if you do that for 10 to 15 minutes when the child is awake, that's fine. Then over the next few days, try to keep it on for 10 to 15 minutes when the child is sleeping and see what happens. The child will pull it out. The next day, you do half an hour. You try that for 2-3 days, pull it out again 45 minutes. But over a period of time, children who need the NIV, which are children with neuromuscular diseases and chronic lung problems, take to it really well and they do very well. And we usually see in 2 to 3 weeks, most families are able to work with us and tell us that the child is using it 6 to 8 hours at night without taking it off. We're able to manage. And that we also do some small things. Sometimes we start with very, very low pressures, lower than the child requires, so that it's easier for the child to get used to it. And then after the child is accustomed to it, we increase pressures over a period of time. So there are a lot of strategies that we use to sort of help families and children get used to it. Mostly it is trial and error because each family works differently. But the message is that if the child needs it, and if your doctor thinks your child needs NIV, your child will definitely take it. Persistence is the key. You need to be persistent and just keep trying and it'll work.
One, Mr. Hemant Gowda wants to know that he feels dryness in his throat and he's not able to use the BiPAP machine for a longer time. Then he feels difficulty in breathing.
So two suggestions, Hemant, if you're using your BiPAP machine without the humidifier or your humidifier is not working, very commonly you will feel that dryness in the throat. So just ensure that your humidifier machine is working. That is number one. And if you're not using a humidifier, please try to use it with one. Get your machine serviced if you think the humidifier is not working. The second thing is that if you're not able to use it for long, we need to relook at the settings that are on the machine, because a lot of times if you are breathing against the machine as well, you may be feeling uncomfortable and you may not be able to use it for long. So try to reach out to one of us, send some photos or screenshots, and we will look at the settings based on your age and your weight and your current status. And then I'm sure we'll be able to help you make that machine more comfortable.
What are the criteria for weaning off the patient from NIV?
So
There's a question from someone. If once we start using, can't we stop it like lifetime? I mean, it's the same thing.
Very good question, because we do wean children off NIV, especially children who have respiratory conditions that are treatable. For instance, if you have an airway problem like a laryngotracheomalacia, you know that your muscles are weak very early on in childhood, but as you keep growing older, the muscle strength sort of improves. So we do periodic sleep studies, or we clinically assess children every 6 months and we decide whether they need it or not. You can do a clinical assessment in conditions that sort of get better over time. Same thing holds good for conditions like chronic lung disease or prematurity, where as you grow older, your lungs get better, and over a period of time, we wean children off. But children who have more chronic diseases, for example, if you have a chronic progressive neuromuscular disease like SMA or Duchenne muscular dystrophy, then you know that you may need it over a period of time and even lifelong, unless you're a child with SMA who gets a disease modifying therapy, so one of these real expensive drugs. Even then, all of our children in our cohort who have received gene therapy, or which are about 34 or 35 children, they have still required BiPAP even 4-5 years post gene therapy. So we don't know how long you'll need it. But for children who have chronic progressive conditions, yes, likely you're going to need it lifelong. For children who have conditions that sort of get better with age, you can wean them off. We do have weaning guidelines available for certain conditions. And when we do titration studies, so when we do sleep studies where we look at whether you need it or not, we can also de-escalate therapy. We can sort of reduce pressures and decide whether you're okay to come off the ventilator. So there are objective ways to assess it as well.
If there are no questions, then we can wind up. Thank you so much. And thank you so much from ORDI.
Thank you very much, sir.
For giving this wonderful
Thank
lecture.
you all.
For throwing
Thank you
light
so much.
on this difficult
Thank you,
topic.
Dr. Aparna.
Thank
Thank
you so
you all.
much. Thank you.
Thank you, ma'am.